This one that I'm going to talk about today is the Partners in Parenting program, which is a multi-level suite of web-based interventions as an approach, a public health approach to empowering parents for child and youth mental health. So I might just start from the beginning, where this really all was birthed, and it dates back to about 2007, 2008, when I first finished my PhD, where I was involved in a large longitudinal study of adolescent development and looked at how family processes, including parental socialization of early adolescents' emotions, and how that's associated with their ability to regulate difficult emotions and their risk for developing mental health problems like depression. Upon completing my PhD, it became really evident to me that...
Does everyone else can see the slides? I cannot see the slides.
No, we can't.
Oh.
No, we have a blank white screen.
Blank
Yes,
screen.
no, we can't.
Right, okay, thank you for letting me know that. Let me try this again. What about now?
Yes.
Yes,
Yeah.
thank you.
Okay, thanks
It's
for
open now.
letting me. Okay, great. So I haven't missed much, do it? We're still in the first slide. So it became evident that early in my research career that there's so much research that's already been conducted, and my PhD only just added a tiny bit into the ocean, it felt like, of research that has shown how important parents are in child and adolescent well-being and mental health. And yet, when I looked into kind of general resources for parents out in the community, it was also quite apparent that a lot of the resources out there in the community were not based on the research evidence that was building up quite a lot out there in the field. So it became, I had this very compelling conviction that, you know, if nobody is translating this evidence base for parents to access in a way that they can understand and hopefully benefit from it, and their children benefit from it, then maybe I'll make a start and contribute that little bit to it. So that then kind of took me down a slightly different track in my career, and really wanted to go into translating research into accessible resources for parents. So being a researcher, I started with the research evidence, and as what most of us would do, we conducted systematic reviews and meta-analyses of what the evidence has already shown in published literature. So this is one that we published in 2014, looking at modifiable parental factors that are associated with adolescent depression and anxiety. So the key findings were there were 4 parental factors that were associated with increased risk in adolescent depression and anxiety. So kind of transdiagnostic factors, and you know, for those of us who are in this field, it wouldn't surprise us: lower levels of parental warmth, higher levels of interparental conflict, over-involvement, overprotective behaviors from parents, as well as higher levels of aversiveness, which include, you know, parental criticism of their children, as well as parent-teen conflict in the home environment. Those were all associated with increased risk of both depression as well as anxiety. In addition, there were 2 other factors that also emerged as predicting adolescent depression specifically, not anxiety, because there's actually a lot less literature on parental factors predicting child and youth anxiety to date still. So those 2 factors for depression specifically were lower levels of autonomy granting, as well as lower levels of monitoring, which were simply defined as whether parents know where their teen is at, what they're doing, and who they're with when they're not at home or with the family. So it was all well and good. We know what the evidence says. It's all synthesized in the published systematic review and meta-analysis. But what does it actually mean in practical terms? So, for example, as we all know, we do all our fancy research. We try to publish them in academic journals and outlets, and most of it is published in forms and languages, jargonistic language that parents in the general community would never access or read. And what's worse is that some of the literature, the evidence that we publish in academic journals could actually be quite confusing. So, for example, by telling parents that there's a sound research evidence base showing that being over-involved in your teenagers' lives will increase their risk of depression and anxiety, but telling parents not to be overly involved doesn't really help, because what is involved versus overly involved. So it's actually quite a tough balancing act, that we expect parents to be able to do. So what we then endeavored to do is to try to translate this evidence into more palatable and actionable strategies that parents can actually understand and hopefully apply in their own day-to-day lives. And we used the Delphi methodology for this. So for those of you who are not familiar with the Delphi methodology, it's one form of obtaining consensus on issues that might not have clear evidence to guide, as well as to kind of to assist with identifying expert consensus, more broadly speaking, that is superior to just one or two experts' opinions, for example. So what we did was we did a fairly comprehensive search, jumping into Google across 5 different sites. And looked for, typed in keywords that we think parents would type in if they were searching for some guidance about what they can do as parents to, support their child's mental health, prevent depression, anxiety, and so on in their teenagers. So we identified just over 400 unique recommendations out there in the literature. This is the gray literature and publicly accessible online resources. We then recruited 23 international experts in parenting and child and youth mental health, and asked them to rate the importance of each of those recommendations. So of the 402 recommendations we found, 190 of them were endorsed by at least 90% of our panel as being important or essential for parents to do if they want to reduce their teenagers' risk of depression and anxiety. So using the findings from the systematic review and Delphi study, we then published what these are, which are parenting guidelines for the reduction of depression, anxiety, risk and impact in teenagers. Using similar methodology, we also published parallel guidelines for parents of younger kids, so primary school age children, age 5 to 11. And again, another set of guidelines which are around adolescent alcohol use and what parents can do to reduce their teenagers' risk of the harms associated with that. So so we've kind of gone through the translation process of research evidence into actionable strategies, but all we ended up with is a set of text guidelines. And we know that most people don't read text-based documents or engage in them very well. And we know even as clinicians, clinical guidelines are often neglected unless, something goes wrong or we need to check something for a very specific reason. So we wanted to find a way to help parents to make the guidelines and recommendations more engaging and appealing to parents to engage with. So one way that we tried to do this is through parenting programs, which we know out there over decades and decades, there have been a whole range of different parenting programs for prevention of child and youth mental health problems. And we conducted a systematic review quite a few years ago now that showed that randomized controlled trials of these interventions have found long-term benefits in child and youth mental health that last up to 15 years in some programs. So that's a promising way to engage parents in evidence-based strategies. We know that when it comes to universal prevention, it's there are less universal preventive programs, especially for parents of teenagers, which is the space that we were operating in with this particular program back then. And we also know that existing programs have various limitations that we would like to overcome. And so the online approach seemed to be a promising way to try to overcome some of these challenges. So mind you, this was back in 2010. So there weren't many online programs back then. And when it comes to any form of digital or technology-assisted programs, we were seeing things like videos and CD-ROMs and pre-recorded kind of interventions that were mailed to people's homes because the internet wasn't so widely accessible back then, but was starting to become more at that time. So we know that on face-to-face programs have these limitations in terms of accessibility and the various logistical and practical barriers for parents getting to the face-to-face program, attending on time, but fitting into their schedule and so on. And so there's widespread challenges around the reach and uptake of even evidence-based programs that are run face-to-face. So that's where we kind of gave us the impetus to try online modalities for delivering parenting programs. We knew from the emerging literature back then in 2010 that there were favorable factors like anonymity, flexibility, and accessibility of online modalities. There was arguments that implementation fidelity is essentially guaranteed because it's computerized. And there were forms of programming and software that allowed branched programming that hence, it doesn't just give you a standardized program for everyone, but allows tailoring to each user's needs and interests. And of course, when we think about, cost effectiveness and, at the cost per individual that could benefit from it, online modalities offer the potential for scalability and sustainability. And even back then, there was already emerging evidence that online programs alone would only go that far with engaging. But then when you have some form of one-on-one or personal contact with someone else, whether it's an administrative supporter or a clinical supporter, like a clinician, the literature was clear that with online programs, the personal touch does make a difference in terms of enhancing engagement as well as intervention effects. So that was all the backdrop of when we developed our program. So the way we went about doing this included recruiting a group of parents that we referred to as our reference group, because we went back to them multiple times. We also conducted focus groups with adolescents in high schools to get their thoughts and their insights into some of the recommendations we were making to parents, and also use some of the insights, incorporating them into the intervention. We also developed a parental self-assessment scale that essentially asks parents to reflect on how they are doing relative to what the parenting guidelines are recommending, which I mentioned earlier. So these are the guidelines based on research evidence and endorsed by international experts as what parents should do to reduce their child's risk. So the parents' responses to the self-assessment scale are then fed into the programming of an automatically tailored feedback report for parents that highlights to them their strengths as well as areas that they can further develop. And then they are offered a web-based parenting program that have interactive modules, giving them kind of step-by-step examples and applications and problem-solving tips for applying the evidence-based recommendations. So in the interest of time, I'm just going to skip through some of these so that we can talk about the later bits. So just pardon me. So the self-assessment scale, as I mentioned there, covers a range of domains. And these are the domains that the parenting guidelines covers. So they touch on the more common topics, on parenting, such as, connecting with your child, communication, autonomy granting, family rules, and conflict within the home. And we'll also cover somewhat less common topics like health habits, how to encourage your child to have a good nutritional habit, physical activity, sleep, and the use of alcohol, drugs, and so on. So the feedback report, as I said, is automatically produced for parents upon them submitting their responses to the self-assessment scale. And then there's a web-based program that parents can then dive into, and it comprises up to 9 modules that they can choose from. And a series of modules are recommended to them, again, based on the responses to the self-assessment scale. So each module is fairly brief, takes about 15 to 20 minutes for most parents to complete, depending on how they choose to engage with the activities. And the modules are timed to release 1 per week, although parents can dive into modules more quickly if they wish to. So here are some screenshots of one of our versions of the program. And so all parents have to do is provide an email address and create a password to create their own account. They then register, provide some information about themselves, which we then use to tailor the self-assessment scale as well as the feedback report to them. So for example, here, these survey questions are tailored to the child's name, and we've named the child Claire in this instance. And then they get this tailored feedback report, as I mentioned, that steps them through each of the 9 domains of the scale. And when they click on the topic heading, it drops down to provide specific feedback for the parent about how they're currently doing, and specific ideas and suggestions for what else they could do to build that aspect of their parenting. They can also access a copy of this for future reference. And then they get to start their online program. So as each of these cards on the dashboard, it's a personalized dashboard for each parent, and each of these cards represent a module in the online program. So the program is an adaptive website, so you can use it on a large screen like a desktop, on a phone, as well as on tablets, and it just adapts to the size of your screen. It has a range of different activities and interactive formats, and has an end of module goal setting exercise, which offers parents the opportunity to pick a goal that they would like to achieve in the coming week before they undertake their next module. And really, it's kind of like, it's akin to homework in cognitive behavior therapy, where it encourages the parent to apply something that they have learned from that module. The module also has videos that shows scenarios, interactive scenarios between parents and teens, and talks about, aspects of a parent's behavior that can be helpful or not so helpful in responding to their child's emotions and so on. At the end of every module, we also have a quiz, which really is not really a test of knowledge as such, but really an opportunity to highlight the key messages in that module and to consolidate knowledge of those. And when parents respond to the quiz questions, they get immediate feedback just to reinforce the key messages again. So some of the evaluations that we've done of our program, which, as I've mentioned, is a multi-level approach. So first of all, at the very first level is the set of guidelines that I referred to earlier that anyone can access universally. With step 2 or level 2, that's where if a parent wants they prefer not to just read a set of general guidelines, but they want the guidelines to be personalized to them. That's level 2, where they complete the self-assessment scale and they get the personalized feedback, single session psychoeducation intervention, so to speak. With level 3, that's where they have the full interactive online experience with the modules that I just showed you. And then with level 4, it's essentially the online modules that I mentioned with the feedback report, but there's also one-on-one coaching that the parent can receive from a trained clinician to help them to further troubleshoot concerns that they might have, or any challenges that they foresee trying to implement the recommendations in the online modules. So as you can see from the bottom there, in this model, we propose that when it comes to universal prevention, when the young person's mental health is still functioning well, or the parent has high levels of confidence and competencies or skills in their parenting, the lower levels of the intervention would be quite appropriate for them. But as the challenges increase, both at the parent level or the child level, we anticipate that parents would benefit more from having more intensive support, including with a trained clinician. So with the various evaluations that we've conducted of the general guidelines, we found that the vast majority of parents who accessed the guidelines reported that they attempted to make at least some change in their parenting as a very kind of brief intervention. Likewise, we conducted a randomized controlled trial and found that the single session intervention was also effective in improving parenting strategies that are associated with reduced risk for adolescent depression and anxiety. Sorry. And then with level 3, we again conducted a separate randomized controlled trial and found promising effects, both in terms of the parenting changes, parental self-efficacy improvements, as well as at a 12-month follow-up, changes in parenting, mediating improvements in adolescent depression symptoms. So with level 4, which is the therapy-supported version of the program, we conducted a single-arm trial and found that also had promising effects on a whole range of different outcomes, from parenting skills and behaviors, self-efficacy to parental distress. These are for parents who are supporting a young person who has clinical level mental health problems, as well as improvements in parent-teen attachment. So kind of going full circle, we've gone from recognizing the problem, identifying the risks and protective factors, developing the intervention, testing the intervention, and then trying to disseminate the interventions. And as already mentioned earlier, so I'm just going to skip through these, we are already rolling out a couple of our programs nationally and are looking at conducting further research to see how we can better reach some of the underserved populations with our interventions as well. And one of the latest things that we're developing is adding a new level to our multi-level approach, where we are training a peer workforce to deliver the coaching for parents so that there's not total reliance on clinicians only. So a whole range of challenges and opportunities. We know that prevention and early intervention are paramount given the huge burden of adolescent mental health problems globally. Evidence has shown that it does have promising effects when the interventions are directed at young people, but there's longer term benefits with parenting interventions that are yet to be tapped fully. As alluded to, there still remains lots of challenges around uptake and reach, as well as the sustainability of these programs, which is, again, one of the things that we're looking at, which includes embedding the interventions into existing settings like health services, parenting websites that are widely trusted and have huge amounts of traffic from the general population of parents, and looking for ways to get the interventions to where parents are at. And I think I'll leave it there. Thank you.
Thank you very much, Marie. That's a very, very efficient presentation and very interesting. And in the Department of Psychiatry at University of Toronto, until her retirement, she was the Director of Research at Sick Kids Centre for Community Mental Health in Toronto. Most pertinent to today's presentation, she's a long-standing collaborator on the International Learning Through Play program and research. And I think you heard earlier that she has had a long interest in Watch, Wait, and Wonder and was a co-founder of that. In addition to that, she's had lots of other involvements and she's a very talented person. Alfredo Tinajero is a human development specialist living in Toronto, Canada. He holds a PhD in early human development, University of Toronto, and a master's degree in developmental psychology. His main professional interest is in initiatives to enhance the well-being and health development in young children and adolescents. He's an advocate of interdisciplinary work in early childhood sustainable development programs. Alfredo has worked as a consultant in several organizations, including UNICEF, UNESCO, Inter-American Development Bank, Brookings Institution, Christian Children's Fund, which is now Child Believe, Founders Network, and the Sick Kids Center for Community Mental Health. He also has several international publications, including an encyclopedia on child development, books, and scientific articles. He currently works as an independent consultant and is a university professor. Alfredo and Nancy, welcome. We're delighted to have you here, and I'll turn that over to Alfredo. There we go.
Thank you, Andy. Thank you very much. Can you hear me well?
Yes, and we see the screen as well. Yeah.
Well, thank you, Andy. Good day, good afternoon or night to everyone. I don't know. It's very interesting how we can be connected at different times of the day. Dr. Cohen and I are very happy to participate in this conference. We would like to thank NOSRAD, the organizers, for the invitation to share with you our insights on the parenting programs and emotional self-regulation in the early years. Dr. Cohen had an issue yesterday with her at her home, some water coming in. So she has been difficulties. I don't know if she's here, but she said that we agreed I will give the presentation and she's going to jump in anytime. Well, sorry, with two computers. Okay. So this is an article that Dr. Cohen, Salasia, Ahmed Torp, and myself published in 2015. I'm going to talk to you a little bit about this article, the history it has. It's actually on Learning to Play program and the focus group data that was collected for many, many years. When I joined the Sick Kids Center for Community Mental Health in 2008, Andrew was there, Nancy was there. We found folders and folders with focus group data coming from around the world. And for us, this was like a gold mine, because this focus group data, we realized it told the story about what was happening in communities in different parts of the world. So again, a gold mine of data, and we decided to start analyzing it, to put it together. But data coming from at least 16 different countries. And the story goes that we developed a methodology to process the focus group data, and this methodology is explained here with the results. This is a 2015 article. And so I will share with you a little bit about the methodology we use and the outcomes. So the data we analyzed in the previous article, it came from 11 different countries. And we asked 3 different questions to collect the data that responded from the caregivers. So the first question was, we asked the caregivers at the end of the LTP program, what have you learned, which is related to knowledge. We asked the second question, what are you doing differently, which is related to practice. What are they doing different in terms of their caregiving? And the third question was, what changes have you seen in your child and your family, which is related to outcomes? For example, the child has, according to the caregivers, a better motricity or higher self-esteem now. So what we did is we processed all this information, this data, and we did it first by create like a template with the possible responses. And then we came up to these three groups I am presenting here: knowledge, practice, and outcomes. And we continue coding the data, and we created at the same time at categories and subcategories. I'm not going to go into detail here about this. You know, this is a very small graph, so don't worry about reading it. But the main point here is that we created groups: knowledge, practice, and behavior. We created many categories and many subcategories, and we were able to code to enter the data into these subcategories. So the main finding of this study was that approximately 50% of the data were coded into subcategories related to social-emotional development and contributing factors. That was very interesting. So caregivers, according to their responses, were very concerned and mentioned that after the delivery of the program, after the 10th session, they mentioned that, for example, I learned about the sense of self. I learned about the importance of attachment. But at the same time, they said, and we are doing something different. For example, we have now a better interaction with the child, and we are playing more. And in terms of outcomes, my child has a higher self-esteem right now. I feel better myself as a caregiver. You see? So we found that approximately 50% of the data were coded into social-emotional domains. And what we did with the data, we tried to return it to the local program so they can process, understand. And in this way, this I think it relates to what Mary was sharing in the last presentation, is sharing the data, sharing the information, and make it accessible to the local programs. This is what we did. And what the idea was to make the social-emotional domain more visible, okay? Because we lack standardized tools to measure child development in a low-income country. We lack that, or very expensive to use, or not culturally adapted. So I think in this way, using qualitative data, we were able to make the social-emotional domains more visible. Now, let me say something about what are we going to cover with Dr. Cohen in this presentation. You see here that this presentation is about emotional self-regulation in the early years. You may wonder, why self-regulation here? And the answer is, for me, that self-regulation offers the opportunity to link science and caregiver practices in a very practical way. So it's easy to understand the links between self-regulation and caregiving practices. In this presentation, the main question is, can the notions of self-regulation enrich the LTP program? So, can the notions of self-regulation enrich the LTP program? How can we use these notions of self-regulation to understand the interactions between social-emotional interactions between the mother and the child? Sorry, I have a problem here. I have my little cat jumping over, so I have to put her aside, if not. Okay, sorry. So the main question, as I was saying, is can the notions on self-regulation enrich the LTP program? And another question is if these notions highlight something we should be paying more attention to within the frame of the Learning to Play program or other programs. So what is the story of self-regulation tell us here that can enrich what we are doing internationally? So let me start here. You may be familiar with the term, what is self-regulation, but I am going to cover it a little bit. Self-regulation refers to the ability of the child to manage energy levels, emotions, thoughts, behaviors in ways that produce positive results. Just have to excuse me 1 second, okay? My apologies. My apologies with that. I have to put the cat aside. The only way to continue. My wife says that she has special needs, that I have to treat her according to special needs. So I was saying that I'm going to start by defining a little bit self-regulation, which is the ability to manage energy levels, emotions, thoughts, and behaviors in ways that produce positive results such as well-being, loving relationships, and learning. Let's say, let me give you some examples. A child who's able to share a toy with his or her peers. Okay, this is an example of self-regulation. A child can delay gratification for a moment. For example, yes, I can wait for the ice cream, or I can wait for something. Okay, that can wait a little bit. Okay, that's something that can define self-regulation. So, to start thinking about self-regulation, there is a key concept that affects its development and the actual use of self-regulation, which is stress. Self-regulation has to do with how we handle stress. Here we have the Simpsons, is a good example of what a stressor can be. So self-regulation has to do with how we handle stress. There are many stresses in the world so that children suffer. So let's say, think for a moment about newborn babies, the stressors they suffer. So newborn babies have to be fed, change diapers, they have to be cleaned, they have to breathe, they are exposed to noises. And let's think about premature babies. Okay, here in this situation they have more stressors. They are have been prematurely delivered, and so the sensory system is not fully developed. So they are going to be more exposed to stressors, and we should take that into consideration. So self-regulation has to do with how we handle stressors, what we do with them. So a definition I can give you is the capacity of the child to bring the arousal level to a normal baseline. For example, if a child is scared about something, self-regulation refers to the capacity to bring this activation, arousal of the central nervous system, and these hormone levels to a basal level, normal level. So this is self-regulation. It has to do a lot with the central nervous system and with the hormone levels that become activated because of stressors. Here we have different stressors that relate to little children. And I'm going to mention a little bit of some of them. Some biological, for example, in nature, which, for example, sugar can affect self-regulation. The lack of sleep can affect self-regulation. Some emotional stressors, such as fear to the unknown, in many times, what is below my bed? This is a typical question children ask. fear about punishment, fear about organizing thoughts. If I am in school, I have to learn to read. Okay, so that can be very scary for children. Stressors of organizing thoughts. What comes first? I don't understand you. And other stressors coming from the environment, for example, bright lights, noises coming from the environment. Okay, so stressors again are everywhere, and little children are very exposed to them. I gave a workshop not long ago, that was last month actually in Ecuador, and I asked preschool teachers that participated in the workshop, okay, what were your stressors when you were little? And the answers, the list of their stressors was endless. So we all are exposed to these stressors. What we have to pay attention to is that adverse experiences related to toxic stress can activate in an unhealthy way, can program in an unhealthy way the stress response system. And Lynn Jones, she knows this very well, what happens with children who were in a situation of war, for example. So the stress response system, the cortisol levels, and the adrenaline and other hormones are activated immediately and become like this response becomes that program that is sustained across life, which is very dangerous and bad for physical and mental health across the lifespan. So what we have to do is, that's the main message for the ECD workers, for example, or those working with children, is try to reduce stressors as much as you can. Now, self-regulation and early human development. This is a beautiful picture. You see the exchange between that and his little baby. And you see how finally they look at each other's eyes. This is very powerful. Self-regulation starts in the early years, develops sensitive periods in the early part of life, and continue developing more or less until the age of 10. We always can learn self-regulation later on, but this is a sensitive period, the first years of life and up to 10 years. Now, to understand self-regulation, we can use this metaphor of the three brains. And believe me, this is very helpful to understand how self-regulation works. So we have, according to this metaphor of the three brains, we have not one brain, but we have three. One, which is in blue, which is corresponds to the neocortex, and is related to the capacity to think, to plan, to communicate through language, to reflect. So this is the neocortex. And keep in mind, please, that this area, the neocortex, is still developing in the early years of life. It's very important to consider this, to take this into consideration. The other brain is the one in red, which corresponds to the limbic system. Here we have the amygdala, here we have the hypothalamus. This is the home of the emotions, it's the home of attachment, it's the home of the hormones that are released. It's the home of the central nervous system activation. So this is the red brain, the limbic system. And the third one is the reptilian brain, which is responsible for breathing and for temperature control. So main message here is that self-regulation has to do between the coordination, between the balance between the blue brain and the red brain. We want both. Both are needed. We need emotions, but we need also the capacity to think rationally. So this is like, if you want, like hot water and cold water mixing. We want the red brain, limbic system, and we want the blue brain, the onocortic. We want them both. Emotions are very important. We are humans because of our emotions also. So what happens in situation of toxic stress, and I feel funny talking about this when Dr. Lynn Jones is present. Okay, she knows this very well, much better than me. In situation of toxic stress, what happens is that the red brain takes over. You see? The red brain takes over, and the blue brain becomes like an spectator. So the main lesson here is that it's very difficult to talk rationally, to try to think, reflect with a child who is under a red brain mood. So we have to always take this in consideration. But in situation of toxic stress, what happens is that the HPA pathway, which is the hypothalamus, pituitary gland, adrenal gland, axis, and the amygdala, this is red brain, are activated, and adrenaline and cortisol are released. So again, the concept of definition of self-regulation for a physiological view is the capacity of the child, the self-capacity to bring this down to a normal basal level before the stressors affected the child. So something else, I have a picture of the vagus nerve. Children, just to make the point here that children described as difficult tend to have a low vagal tone. And this is very important to take into consideration. Because in self-regulation, one of the first steps is to try to see the behaviors not as a result of that the child is difficult, but as a result of there is a stressor happening and affecting the child. In this case, children with a low vagal tone have the tendency, because they feel uncomfortable for many reasons, they tend to be more difficult. But this is not intrinsic to the child again, it is something related to a stressor they are having. Now, I'm going to talk about two terms, and here I think I will connect with Dr. Chapman, what she was talking about. This connects to Watch, Wait, and Wonder. These are two beautiful, powerful concepts I will talk about. The first one is called limbic resonance, which is like a Wi-Fi between the caregiver and the child. And so it's a connection, a wireless connection of the red brains of the caregiver and the child. This is beautiful, very powerful concept. Limbic resonance is an automatic synchronization between two brains. It's non-cognitive, it's purely red brain. The connection is established through the senses, and the child scans the experiences offered by the environment. Let me give you an example of this. This is a very personal example. When my son was 6 months old, we put to sleep him in a separate room. And he used to wake up at 1 o'clock, 3 o'clock in the morning. Okay, he's scared, naturally. But we have a way to communicate. I have a way to tell him I am here from my own room. And he had a way to respond. I hear you, Dad. Okay? And my emotions feel that you are here with me. And this way was very simple. He woke up, and from my bed, I used to just repeat like a dove, like the sound of a dove in Ecuador is ooh, ooh, ooh. And this was something that he could repeat. He had the capacity verbally to say it. So he answered back, from his room. Ooh, ooh, ooh. And we had a brief communication. This was so powerful. This is limbic resonance. It's non-cognitive. It's a synchronization of two brains. It's the brains vibrating like two violins vibrating together. The second concept I would like to introduce, again, this is very powerful, is this one on biobehavioral synchrony. And here the author is Dr. Ruth Feldman. She's a researcher from Israel. It's fantastic work she's doing. So she developed the concept biobehavioral synchrony. And what she found is the following. Again, take attention because this is so powerful. In moments of affection and deep exchange, the adult and the baby come to synchronize their heart rhythms, hormone releases, oxytocin, and activation of brain patterns. Look at this, this is so powerful. So that means in this picture, when the mother is hugging the little baby, all this is happening. This is synchronicity. Oxytocin is a hormone related to that favors attachment. So pay attention to this. So the hormone release during these moments of intimate contact is oxytocin, which is a hormone that allows the child to be relaxed and to enjoy and make these little moments longer with the mother. Okay, I am with you. Okay, I'm with my dad. So oxytocin are released at the same levels, okay, like as in synchrony. And the same happens, as I said, with the heart rhythms, the activation of the brain patterns. So we know that we have alpha, beta, different waves. Okay, the waves are synchronized. Okay, their thoughts are synchronized.
A few more minutes, Alfredo.
Yeah. So this synchrony is defined by Dr. Feldman as a dance, and she says it's another way to understand attachment. So this is oxytocin, plays a fundamental role in attachment formation and synchrony. Buffers the activation of cortisol and is related to another good hormone, the dopamine, which is related to happiness, and favors the immune system response, oxytocin. It helps to manage stress related to social interactions. This is something that captures everything is said here, okay? Love is the link between the body and the mind. So according to Dr. Feldman, there are 4 key behaviors of the mother toward her baby to favor this synchronicity. The first one is look to the face, look to the eyes deeply, provide positive affection, vocalizing baby talking high frequency, and skin-to-skin contact with affection. So through these practices, mothers help children to create synchronies and patterns of rhythms, tempos, and dynamics. So the mother and the child, or the father and the child, dance together. So in this last part, I was just trying to reflect on something. What is the use of all these? Remember the question, what can be the contribution of notions of self-regulation to learning to play? So I am going to ask just a couple of provocative questions to not give an answer myself, but to ask questions. So the Learning to Play program, we know it's very directed to love, affection, care, tender. the main reflection, the first reflection I have is that we need also the other side of the coin. Not just to look at these, love, care, affection, but also to look at stressors, also to look at situations where children are in difficulties, in problems, psychological, whatever, which comes from the work of Dr. Chapman, and especially the Dr. Lynn Jones. Okay, learning to play has to be about both sides of the coin. My questions to reflect are the following. With this, I finish. Should we be paying more attention to stressors and the way to reduce them? Should we do more about promoting touching, talking softly, looking deeply into the eyes? Next question is, are premature babies and other children with special needs being overlooked within the LTP groups? And this is very, very important because, in my opinion, the premature babies, for example, they need some very particular special stimulation, but in order not to overload them. They need skin contact. They need something else. And perhaps the LTP program can be enriched and first be aware that these children have special needs, for premature babies especially. And the final question is how can we support biobehavioral synchrony in mothers suffering from postpartum depression? So, Dandy, I don't know if we have more time, but I would like to ask Dr. Cohen if she has something to say, or.
We're running quite a bit late here, but thank you very much for your presentation. There are some things in the chat box which during the break, if you want to take a look at those and try to respond to those. I'm glad that Nancy could join us for part of the conference, and delighted to have you both here. So what we'll need to do now is take a break for about 5 minutes. When we come back, we will go into the breakout groups, and so we want you to be here back in 5 minutes, and then you'll choose the group that you go into. There's 3 different groups. The one is.
Sorry to interrupt, but isn't my talk prior to the breakout groups?
Say it again.
I thought the breakout groups followed my talk, our talk.
Yes, we're going to have a break now. I'm sorry, that's right. Yeah, we're going to have a break now, and then Lynn and Asmanu are going to do a presentation, and then we go into the breakout groups. Thank you very much, Lynn. Sorry about that. So take 5 minutes, come back, and we'll have another presentation, and then go into the breakout groups. Okay, thank you. We'll keep things open, but we will take expert general practitioner with more than 20 years of experience working as a clinician, manager, and trainer with rural and indigenous communities in low resource environments, including Ethiopia, Haiti, Mozambique, and Belize. He has most recently developed and delivered maternal and child integrated physical mental health training courses for mothers and infants under 3 in Bosnia, Northern Ethiopia, Venezuela, and Guatemala. He has expertise in establishing emergency primary care services from scratch in a variety of settings, serving conflict and disaster affected, displaced, and refugee populations. I have such deep admiration for both of you, as that you just go wherever there's a deep, deep need, and we're delighted to have you here this morning. Over to you, folks.
Okay, thank you so much. A lovely introduction. Can you see a slide? And it's
Yes.
full screen. Great. So we can proceed. I'm trying to move the photographs out of the way of both my text and like that. I'll put them there. Where can I put them? Yeah. No, they're just. So I'm trying to get the photographs so they don't block the slide clicker. Okay, great. Well, thank you so much for inviting us. And we're going to talk about this intervention that we've developed, which we've done since October of 21, we did it online, first of all, in Peru during COVID with adolescent Venezuelan refugees, but then we actually developed it into a real life intervention, which we've done in a few countries, and we're going to describe it to you. I should say that unlike the rest of the eminent speakers, I don't have any research evaluations about it to present because we haven't evaluated. Anybody who wants to fund us to do that would love to do that. But what we draw on in the intervention is interventions that others have developed. We steal everybody's, including learning through play, and put them together. So we feel that what we're doing has an evidence base. So what's our approach? Well, last year I talked, I don't know if any of you were here, but I talked about turning the LTP approach, which I love, into a group approach, which I first really used in 204, 5 and 6. And the picture there on one side is me doing learning through play as a group intervention on the Somali border in a refugee camp in 2007. Now, here's the funny thing. Next door, that's my husband, as Marmo, teaching vaccination and child malnutrition and how to recognize childhood illnesses to more or less the same bunch of mothers, but we were working in separate boxes. And this became to me increasingly bizarre. All my life in the humanitarian world, we've separated everything out. Now, part of my work in the adult world has been getting primary healthcare workers to put mental health into what they do in the ordinary clinic. But we weren't doing it with children. Mental health isn't properly integrated into physical health, and physical health isn't integrated into mental health. And really a holistic approach works much better for a number of reasons. I mean, your obvious one is breastfeeding, because that is good for both nutrition and fostering love and the that lovely word that Alejandro used, I've now forgotten it, I wrote it down. But that bioauthentic approach, you need both. And indeed, I found myself in 2010 being asked to write a leaflet about adding ECD to nutrition programs for that famine in Somalia. There's another one. And I was going through all these leaflets saying how good breastfeeding is good for you, including ones by quite famous NGOs. And they said things like breastfeeding is really good for nutrition, blah, 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 blah. And they didn't mention warm relationships. There's all this box thinking. A holistic approach emphasizes both education and nutrition. It includes infants, but it also includes parents. It includes children with disabilities. And if you're very lucky, and we often aren't in the places we work, it includes fathers. Okay, so WHO and UNICEF have got much better. There's no question. And they have this thing that's been around since 2018 called the Nurturing Care Framework. Now, I hope you can see that nice diagram on the slide and take a careful look at it, because they present it as revolutionary, but of course it has lots of things that all of you experts in the audience know has been around a long time. And it is much more holistic than things used to be, because children's physical health and children's mental health are brought together along with their security. That is brilliant. So safety, security, physical health, food, love, wonderful. There's something missing. Audience participation moment. What is missing in this framework? What's not there, or who's not there as a topic? Anyone? I don't know if you want to unmute the audience, or anyone wants to shout out. I'm not able to read chat and teach at the same time, so please just shout if you have an idea. No? Come on, guys. Look, there are parents, but the word mother does not appear anywhere in this framework. There is no mention of mother. Well, you might say, well, that's implicit. I mean, lots of things are implicit, but they need to be mentioned, and it isn't. And so we decided that when we ran a program, we were not only going to add in mother's mental health, which was dealt with so beautifully yesterday, but we're going to add her physical health. I've not seen a program do that, include mother's physical health in an ECD program. And we decided we would do it. And we would also include her reproductive health, which is sometimes kind of snuck in, but doesn't always come. And as Mum is going to detail how he does that, but before that, I just want to say a little bit more about the underlying principles of our approach. So, number one, it's got to be fun, otherwise no one's going to come. The mothers have to feel empowered. We want the knowledge to be delivered in a really easy, friendly way. We want an opportunity whenever we do it for others to learn how to do it. And the lovely thing about a group intervention, whether you're doing it in, sitting in a field or in a tent, as I am here in northern Ethiopia, is, a group of people can sit around the outside and watch you do it. And it's got to be deliverable in a short period of time, because we're usually working in situations, or often working in situations, where people are moving, or they arrive in the middle, or they're leaving because they're climbing mountains to cross the border into Europe the following night. So not only has it got to be short, but if they only come to 3 sessions, that's okay, because they got something from those 3 sessions. We focus, there's no rule about this, but we focus on 0 to 3. I know you could go on higher, but 0 to 3 is a really good group. They have particular needs. If you try and have children who are older, they have other needs, it's a bit difficult to mix them. And you have to be completely adaptable. And if fathers are around and can be included, that's amazing. Who can deliver it? Well, we do it, but over the year, we've learned and we've had it delivered by everybody and anybody. And in the picture you've got there's the the nutrition staff from the NGO in Ethiopia. He's delivering the program now. There's no reason he can't. Mothers are ideal if they want to pass it on, and they need a bit more support. I'll talk a little bit about training in a moment. What do you need? You need a safe space. This is Guatemala, and this lovely space they gave us, which was a large barn, had a very large pond next door, which made me rather nervous because the children were running around. So we found a way to kind of fence off the open door of the barn. You need to have a time that women want to come, otherwise they won't come. It's a good idea to provide some food and drink. And of course, I was working in a post-COVID environment, so I became quite obsessional about cleaning everything before and after use. So, some examples. This is the International Organization Migration Shelter in Bihać on the northern border of Bosnia, on the Croatian border. Staff were amazing, and they gave us the dining room to work in. There was also a mother and baby caravan in the yard, and everybody wanted to come to the program. So unusually, we actually delivered it in lecture format to a full hall every evening. And as you see, there's one very attentive 3-year-old in the picture. And we had to do multiple languages, because if you're working in that kind of refugee environment, we had at least 4 languages. What we did is we sat translators, which it was great. There were cultural mediators in the center, and they sat next to the appropriate language group, so we had enough time. But it didn't allow for the interaction between mother and baby that we want to demonstrate. So we also ran parallel sessions in the caravan, which the mothers and babies came to, and they really enjoyed them. In northern Ethiopia, we took over a child-friendly tent space. They very kindly gave it to us in the mornings, but actually we moved outside on quite a few days, and the mothers gathered. We had the 10 sessions in the morning, and it was really one of the nicest places I've worked. We had a circle of observers around the outside. Now, just to say, this program does not have to be delivered in a refugee displaced environment. In Venezuela, we worked in 2 communities with vulnerable mothers, impoverished ones in a maternity hospital in a very poor part of town, and fishermen's wives on the coast of a Caribbean island, again, a very poorly educated, impoverished community. But the lovely thing about that is that fishermen go off for 5 months, and then they're home for 3 months with nothing to do. So it was one of the places, as you can see in the picture, where I had fathers attending, which was just delightful. And we also, in Guatemala, the mothers have lots of children and no one to take care of them. They brought their older children. And so we created a play space, a supervised play space for those, because the older children aren't interacting in the same way with their parents, and we have to address their needs as well. So what do we do? 10 sessions, and this is what we cover in those sessions. The first week is 4 physical health sessions, as Mama's going to detail in a moment, and 1 general introduction to child development. Now, the child development sessions that I do, I'll describe in a moment, but they are a condensed version of of learning through play. Basically, everything else is something slightly different. So I'm now going to hand over to Asmamo.
Yeah. All right, I'm Asmamo. Really, I'm delighted to participate on this conference. Hi, everybody. Just I will try to show you how important are these sessions. And breastfeeding is possibly one of the most important sessions. As the slide shows, it is important for the baby, mother, family, and the community and the environment in short and long terms. For example, the environmental benefits are that there is no plastic involved in breastfeeding, no transport, no carbon footprint, no need to cut firewood to warm the milk. And it is simple act with both nutritional and emotional benefits. As Dr. Alfredo mentioned, biosynchronicity, this is a key opportunity. Currently, only 44% of the world breastfeed. Universal breastfeeding would prevent 800,000 deaths in children under 5 per year and 20,000 maternal deaths from breast cancer. When we do these sessions, what comes up is that almost all mothers in different societies know how important is exclusive breastfeeding. We need to get across the exclusive means just breast milk. It does not include formula and the water. In the second session, we cover recognizing malnutrition, childhood illness, and the importance of vaccination. For example, in Ethiopia, among children under the age of 5, the prevalence of stunting was 37.7%. Stunting means an indicator for chronic malnutrition, on which 12% were severely stunted and 7% had wasting. Wasting is just an indicator for acute malnutrition. Stunting comes from inadequate complementary feeding and has adverse functional consequences on the child. Wasting reflects infection and poor nutrition and affects almost 50 million children at any given time in the world. There is an immediate risk of early death and the increased risk of poor development. Also, we need to mention that childhood obesity is a significant and a growing health problem in the world. 3 in 10 children in adolescents in Latin America and the Caribbean are overweight. There are significant health outcomes associated with childhood obesity, including the presence of cardiovascular risk factors and the greater prevalence of various medical problems, including insulin-resistant type 2 diabetes mellitus and the different metabolic syndromes and orthopedic complications. Next. The diseases on this slide are child killers. Mothers need to catch them early. To teaching the important signs and the symptoms in childhood illness, including fever, cough, diarrhea, dehydration, parasite prevention and the treatments, common skin infection, and so on, are vital. This helps get early intervention by the doctors to prevent the complications and the death on the child. Also, now post-COVID, we need to re-emphasize the importance of vaccination as rates are falling. Thanks to vaccination, children can protect against more diseases than ever before. Some diseases that once injured or killed thousands of children have been eliminated completely, and others are close to extinction, primarily due to safe and effective vaccine. Polio is one of the examples. Smallpox vaccination eradicated that disease worldwide. Rubella vaccination has decreased the risk of pregnant women will pass this virus onto their fetus or newborn. Measles vaccination prevented more than 23 million deaths between 2000 and 2018. Vaccination saves 2 to 3 million children's lives in the world right now. Okay. As Lynn mentioned, just women is the main, mother is the main stakeholder in ECD. So we emphasize in women's health. Women's health is one of the most popular sessions in our teaching because usually it is neglected. Women face particular health issues, and the refugees and the displaced women are often discriminated against. A sick mother affects children, family, and the community. For example, 16.5 million children worldwide have lost their mother, father, or both parents due to HIV/AIDS-related illness. When, as you see on the slide, when women take care of their physical health, it has multiple benefits, as the slide shows. A woman who takes care of her own health, take care of the health of her babies and the children, and it's good for the community and the nation. So we show women how to do self-examination of their breasts, remind them to get pap smear if available. After sessions on these topics, mother came up and asked questions. Just that happened in Bosnia. A woman with breast lump and another with chronic vaginal bleeding approached us for advice, and we advised them getting checked. It can be difficult with mothers on the move. For example, in Bosnia, those services were available. Also, mothers anxious to cross the border to Croatia did not want to stay for checkups. That was very sad. As you see on this slide, reproductive health is very important because it includes safe sex and family planning. Just in 1 minute, 380 women become pregnant, half of them just without interest. 110 women have a pregnancy complications. 100 women undergo an abortion. Just 40 are performed under poor condition, illegally, without experts. Just one woman loses her life per pregnancy-related causes. That means 57,000 something, no, 1,440 women die every day, pregnancy-related problems, okay? Next one. So just this is in Ethiopia, arranged and underage marriages are still in practice in Ethiopia. Also, it is against the country's law. This obviously has negative impact on maternal and the child health. So allowing the mother to share their own view was really important. One Ethiopian mother described her own experience of child marriage and abuse, which she saw as acceptable. Other mothers challenged her on this and said she should not accept it. For many mothers, at least their first pregnancy is unplanned. So discussing contraception and the risks to the mother during pregnancy and what to do is another key topic. So these topics are very important, especially in low-income countries. And just I will give the opportunity for me.
Okay, so as Mama does those 4 sessions on women's health, and then I come to the children and mothers' mental health. And we start with what the children need to develop. Well, those of you familiar with learning through play materials will recognize the pictures. We take this Q&A form, and in this situation, I do need pictures. I can't use children in the group because I want to have women understand what the brain is. I ask what the small naked child needs apart from food and water, and it leads to a discussion on the essentials of child development. It always takes a bit of time for the mother. They'll say clothes, they'll say food, they'll say water, a nice house, I say, and then somebody says love, and they get a round of applause. Physical development, again, I'm not going to go through the learning through play approach because you're familiar with it, and I love the way we use it to discuss. There are always a range of babies in the room, so we discuss who's using what and what stages their children have got to, and we I rarely have to correct mothers in any society on their knowledge of physical development because it's always the thing that mothers know best. What I've also introduced, which I love doing and the mothers love doing across cultures, is something called developmental movement. If you've never heard of it, look up Veronica Sherborne, developmental movement. She was a global phenomenon. I was lucky enough to have her actually teach me directly in. And what it involves is using movement, using the natural games that most mothers play with their babies to show how these increase self-confidence, awareness, flexibility, coordination, and also building relationships through empathy. It's a whole workshop in itself. I hope that I can, it's a tiny moment of it. Mothers are coming up with their own ideas. It's such fun, this session. Anyway, I'm trying to pass on to the next slide. There we go. How to play, that's already been well covered. Thank you. Lots of the principles from the 3 W's are the same. Go over how to play with your child, talk about the importance of at least 15 minutes a day where you do what is basically the WWW approach. I don't call it that, but it is following your child's lead, not interfering, showing love, so on. But we also do something else in this session, which is use recycled materials that we've all gathered from our homes or wherever to make toys. And this is such a lovely interactive moment. I just love this drum. Don't you love this drum? Isn't that amazing? Okay. And then on to love and attachment. Again, using much from the LTP material, but I've added in something quite exciting here. I've discovered that across the world, again, Latin America, Europe, and Africa, people all love this. You can find it on YouTube. Watching, and I know they were rather unethical, but there they are, they're on YouTube and they've been done, the Harlow experiments on monkeys, where he shows the different behavior of the baby monkey when offered food or offered a warm, nurturing mother-type monkey. And I learned all about this. I don't have time to show you the film or discuss it in depth, but I learned this when I did animal behavior with Nico Tinbergen back at Oxford. Lovely. And I suddenly realized it's all there. And we show this film and we ask mothers to comment. And they, you know, an illiterate Guatemalan mother gets it and wants to discuss it. And how important is attachment. And it's important for baby monkeys and it's important for us. Communication and understanding. I combine these. This is a 10 session, right? So I've got to combine some things. And I combine communication and understanding because guess what? They fit together. They fit really well together. And we look at what we mean by communication. Again, it's all Q&A. What's verbal, what's non-verbal, what gets in the way of good communication, a very important discussion. Or look at the mother on the bus in Belize. I won't do Q&A with you, but as you see, she's got her baby slung in her arms, but what's she paying attention to? All the mothers comment on this photo, and we all talk about the dangers of digital phones. And we talk then about how communication fosters intellectual development, how play will help. And I have this slogan that I use, trying to sell it, charge a lot, love, play, communicate. And so each session, one session builds on the other. Yes, I just have to do, this is a lovely moment of teaching. We always ask mothers to share games and songs that they have, and this is this Ethiopian mother in northern Gondar sharing what she does with her baby. Isn't she gorgeous? I'm sorry, I can't show you more. So, okay, now some other sessions that don't come in your LTP manual. Understanding and coping with grief and loss. This is obviously a very important session if you're working in a war zone or with a displaced community because they've all suffered losses even if no one has died. And one of the ways I start is saying, should we just talk about what we've lost? And this is a list that came up in northern Gondar. I've got time to read it to you, but you can grasp it. We're only 50 kilometers from the front line, so loss of security and feeling safe was quite a big loss. And these internal losses, identity, security, feeling of a safe future, what's going to happen to my children, these can be as big as the external losses of family, friends, home. And then we talk about how we're feeling. And this session clearly it's a very powerful session, and it can, I may, you know, run on longer if we need to, or pick up individual women to talk to later, but I found it a very useful session to run. And a second part of it is to talk about how we cope. And in Ethiopia, they have very profound rituals for dealing with grief, which are very good because they all involve being together. Coffee is a key aspect. Sharing experiences, talking, sharing meals. This is actually a photograph of my own family because my mother-in-law died a year and a half ago. So I was very much part of those rituals and understood them. And the mourning practices. And everybody, what happens with displaced populations is that the appropriate mourning hasn't been allowed to take place because they're on the move. So they couldn't do the ceremonies that they normally do. And one of the requests that came out of this group was, can we have some mourning ceremonies, and maybe it will be a collective one. We can discuss this more in the breakout groups if people are interested. The other side of this topic, and it's the second session, and I may do it first or second depending where I am, is talking about stress. Now, this is not about toxic stress in babies, this is about stress as a whole. What makes you stressed? And again, how do you cope? And it's so interesting how many good ideas women have about coping and the things they do, including simple things like breathing and stretching. They have these ideas themselves and reinforcing them. And guess what? Playing with children, going outside, being in nature, all these things. We discuss them and how easy they might be able to do in the places that they are in. So I'm zipping through this. I've only got a couple more slides. Helping our children be good, absolutely key. In almost every place I work in the world, unfortunately, including the UK, physical punishment is still common and seen as effective in spite of all the research now that we have showing that it's not. And so having talked about love and play and communication, we can now get across the message that if you love the good and praise the good, yes, praise, and ignore the bad, then you can actually turn bad behavior around quite quickly rather than getting upset and paying lots of attention to the bad stuff and beating. And of course, beating goes up in stressful environments. It's a very productive discussion. And again, any of these sessions you want to hear more detail about, I can go into later. So this is what we learned from, we haven't done a formal evaluation, but we do a qualitative, we do a day where we sit with the mothers and we say, we want to improve this. And we spend half the day hearing from them, an hour and a half session, hearing from them what they liked, what they didn't like, what they think we should drop. Now, the interesting thing was they didn't want us to drop anything. And the most popular session across 3 parts of the globe was, guess what? Women's health. No one in all these places had ever bothered to teach these women about taking care of their own health. That didn't mean they didn't know. There were notices up in surgeries. But no one had sat down and said, this is really important. You're a mother. Your health really matters. This is how you examine your breasts. So I am not dropping these sessions. The women love them. They also love the session on positive discipline. When we say, can we leave anything out? The answer is no, teach it all. So that's rather interesting. They have quite a long list of things they'd like us to add. I don't know how to do that in 10 sessions. So really, I'm not going to say any more because we've got breakout groups and we can discuss more for those of you who are interested. And that's it, Andrew. I'm sure you're delighted that I'm finished. Oh, it's film. Oh, yes, I was telling this a little bit more. Yes, this is a very 30-minute, okay, 30 seconds of film. Please note this picture because what I also love about these groups, thank you for reminding me, what I love about this group is I said, okay, have a separate group for the older children, but the children with particular needs, you can include them in the group and they will have a great time. Can you see here? They're actually sharing games they played as a child, and the young lady here is joining in. I just caught a moment of her on film, but she joined in. She came every day. She helped with the children. I've had children with Down syndrome or developmental delay in every single group I've run. Mothers always say, is it all right if I bring my child? I say, of course. And we will adjust the group to the needs of every child in it. And that seems to be a very lovely thing to do. Okay, thank you very much.
Thank you very much, Lynn and Asmamaw. And I know that those
It would not have been possible, the way the regular meetings happened. And I think from the first conference, we have moved ahead, and looking at the coming years, how we can further develop this. I did attend part of the 3 breakout rooms, and I'll come to it. I would also like to thank all the brilliant speakers which we have had yesterday and today, and it's reminds us more about why it's important to come together, learn from each other, and in one of the groups, my colleague Dung talked about reverse innovation, and that is again looking at the 360 degrees, how we can learn from different parts of the world, and particularly with technology. Just imagining people going to bed while we were having this meeting, and people waking up at the time, and different parts of the world coming together has been brilliant. And talking about the different talks, the other thing is also about that we more and more recognize that one size does not fit all. So at different times, with different populations, with different groups, we would need to utilize different approaches. And so talking about what, say, I have learned today is starting with the first talk by Joe and Joe was about watch, wait, and wonder. And this is something I've been talking to Nancy for a number of years. It was brilliant to hear the talk and look at how can we apply watch, wait, and wonder in different settings, say Nigeria, say Pakistan. And in Pakistan, to my understanding, we did do a translation and a cultural adaptation to our setting. So that was very helpful. And then we moved to Mary Yap, and she talked about modifiable factors. And one of the things I was, when looking at it, there's also a concept called expressed emotions in different mental health difficulties. And the modifiable risk factors which Mary was talking about, to me, it seemed very similar about how the critical comments, over involvement, hostility are not helpful emotions, but warmth is a protective factor. So seeing that there, and trying to make a link with origins of mental health difficulties, because most of us would know that 50% of the mental health difficulties have their origins before the age of 14, and 75% of the mental health difficulties have the origins before the age of 25. And I think it's interesting how WHO has redefined adolescence and talks about now till the age of 25. So we've got this window of opportunity. And the other thing which I found very interesting was from Marie's talk is that a number of interventions are going on. We should give credit to the third sector as well, who are providing these interventions. But they are not utilizing for which we have got most evidence for. So there are a number of evidence-based interventions. So we need to look at how now WHO defines instead of low intensity interventions, what are scalable interventions? And what I was hearing and listening today from colleagues is more about what seems to be scalable interventions. So if we could have, say, one session interventions, that's brilliant to be able to then build from that. And the other thing I've learned as a grandparent was the focusing on even my what parenting strategies or what my factors are I can learn from. Like she said, what is over involvement? So I can say to people, don't be over involved, but what does really over involvement means? And that takes me to the next talk by our colleagues Alfredo and Nancy. The way it was explained about emotion regulation and self-regulation was, came out very, very clear. And we need to look at when Alfredo talks about the limbic resonance and the biobehavioral synchrony. How can we bring it into what existing interventions have? So we have worked a lot since I met Andrew more than 20 years ago. I think we continue to develop and grow the parenting intervention, learning through play, but there's a lot to learn from others and how this can become more acceptable, more feasible, more effective. The next one was by Lynn and S. Mamo. And I think it's so clear, but I never thought of it, about this whole mental health and physical health. You cannot keep it separate. So I am going to reach out to both of them and look at how can we bring it in. When in countries like Pakistan, the rates of, unfortunately, stillbirths, neonatal mortality, maternal mortality are very, very high. They also talked about engagement with dads. So with us, it has been brilliant in Pakistan. They started with watching the groups from the windows, but recently we have been funded to look and work by Grand Challenges Canada to work with partner inclusive 2,500 dads, and hopefully we can talk more about it in our next meeting. Finally, we have got 1 minute left. The breakout rooms, each one, the first one, just the interaction and introductions were very interesting. We're good to have my colleagues from Mercy Care there. I visited the digital one. There were questions about regulations and approvals and how do we adapt it. And finally, the talk about Lynn was also very interesting, of how do we bring it forward more, the excellent work which is going on to scalable, that kind of work. So that ends our time. Thank you very, very much, all of you. You all have been brilliant audience. Some people even waking up at 4 o'clock in the morning. And we look forward to meeting you all next year. Thank you very much.
Thank you.
Okay.
Thank you, friends.